Okay, so we're going to discuss about the therapies in Boston ICDs. So this is the first case, and you see all the details in the text. Initial detection VF, a rate of nearly 300 beats per minute. One shock is delivered. You see here the impedance of the shock. It's a single coil lead, so it's normal value, 76. And the duration here of the charge of the capacitors is something around 10 seconds. So just a simple tracing to introduce. What do you think, Hugo-Pierre?
Well, looks definitely like VF.
Yes, it's probably a VF, so it's a CRT device, CRT ICD, and you see some of the specificity. I don't think you were there the previous week. So in Boston, there are many markers on the tracing. Sometimes it's a bit difficult to interpret, but you see there are many markers. You have 3 channels: atrium, right ventricle, and the shock channel between the coil and the box. And as you said, it looks like really like a real ventricular fibrillation. And the tracing that you see that there are many information here. It's an unfiltered channel. The device does not work on this channel. It will work on a filtered channel. But what you see is the unfiltered channel. So you see a lot of details, a lot of information here. Okay, so now if you think about the counters, do you know how it works?
So it's 8 out of 10,
Yes.
and then we have the marker V episode.
Yep.
And then starts the duration.
Yes. So how does it work here? 1, 2 for the VT counter, and then VF. How does it work for the VT counter?
For the VT counters, so it's 8 out of 10 also.
Yes, but so VF, so the VT counter is 1, 2, and then the VT counter.
So 3,
4, 5, 6, 7, 8. So what you say is that for the VT zone, the VT counter, you have the 8 out of 10. So at this time, we'll start the initial duration for the VT zone, okay? But if you see then, just the VF counter, it's going to be 1, 2, 3, 4, 5, 6, and 2 beats after the marker V episode, you have fulfilled the criterion of 8 out of 10 for the VF zone, okay?
Yes.
So at this time, we'll start the initial duration for the VF zone, okay? So in parallel, you will have the duration for the VT and the duration for the VF zone. But if the duration of the VF zone is still ongoing, then you will not deliver therapy for the VT zone. You will wait until the counter for the VF zone is not fulfilled anymore, or the initial duration of the VF zone will be obtained. You understand that?
Yes.
It's clear? So at this time, start the duration, initial duration for the VT zone. On this bit, start the initial duration for the VF zone. And now, during all the duration, which is the initial duration, you need to fulfill the criterion 6 out of 10. So initially it's 8 out of 10, and then from this bit for the VF zone, you still need to have 6 out of 10. Okay?
Yes.
You see that it has been programmed like the new guidelines. Here you have the marker V detect. What does it mean?
So it has fulfilled the criteria for the duration.
Yes, it's as I said, it's the new guidelines. It's 5 seconds program for the VF zone. Okay.
Yeah.
From here to there are 5 seconds, and during these 5 seconds, on every bit, you have at least 6 out of 10 fast cycles. Okay. So at this time, start the charge of the capacitors.
Yes.
There is still a confirmation here. You still need 6 out of 10. You go to the end of the episode. At the end of the episode, you have the marker charge. Okay, it's the end of charge now. Okay, what happens here?
So now we have a blanking of 135 milliseconds.
Yes, 135 milliseconds. Then the next cycle will not be analyzed. You see this marker here. You will see every time at the end of the charge, the next cycle, which is detected at the level of the ventricle, you will have this marker. It's unclassified. And then 1, 2.
And we need 2 out of 3 to deliver.
Yes, that's the confirmation. First, there's a divert window. At the end of the charge, you cannot deliver the shock before 500 milliseconds for any reason. I will not give you too much details, but from the end of the charge to the shock, there cannot be less than 500 milliseconds. But once end of the charge, blanking 135, one cycle is not analyzed, and then you will analyze the next 3 cycles. And if there are 2 fast cycle out of 3, you will deliver the shock on the second fast cycle. Okay?
Yes.
Then the shock is efficient. And so you see the main reason why we implant ICD, the idea is to correctly detect a ventricular fibrillation and to treat it with an electrical shock. Okay? Now, if you consider the time from the onset of the arrhythmia and the delivery of the shock, first, you will need to have 8 out of 10, so something like 2 seconds, okay, of arrhythmia. And then the initial duration, in the new guidelines, it's 5 seconds, so 2 plus 5 is 7 seconds. And then you need to add the charge of the capacitors, it's written here, something like 10 seconds, so 17 seconds. And then at the end, you have the confirmation of something like 500 milliseconds. So something in between 17 and 18 seconds between the onset of the arrhythmia and the delivery of the shock. Okay?
Okay.
So the amplitude now, I will show you briefly something, but you know, in the guidelines, these are the guidelines for Boston. Remember, it's quite precise in terms of therapies. You see that in the VF zone, what we have, all shocks, maximum output, okay? And of course, the idea is that you need to adapt to the characteristics of the patients, but in general, what is recommended is to program only maximum output shocks, okay? We will rediscuss about the quick convert, and we will discuss also about the ATP in the VT zones, okay? But in the VF zone, it's quite simple as programming. All shocks, maximum output, okay? But there can be some specificity sometimes. What do you think about this one? You see the trace, the text?
Yes.
So it's an episode of VF.
Yeah.
261. And the first shock is 14 joules. So far from being the maximal output here.
Yeah.
Okay? But if you look at the details, I don't know if I still have the details. Look, date of birth. This is a young patient. This patient is 10 years old patient who was implanted because of aborted sudden death and who presented many episodes of ventricular fibrillations, very fast and polymorphic arrhythmia with syncope anytime. And this is one of the episodes. What do you think here?
Well, there's a sudden acceleration, and it looks like, well, VF or polymorphic VT.
Okay, so 1, 2, 3, 4, 5, 6, 7, 8. You see, there is one VS, but you have 8 out of 9, so it's okay. V episodes, and then you will start the duration, initial duration for the VF zone, and you will see that in these patients, it's programmed very short. It's 1 second.
Okay.
The old programming, I will say, and then start the chart of the capacitors. And since you deliver only 14 joules, you see that the chart of the capacitor is very short. At the end of the charge, 135 unclassified cycle, 1, 2, fast, boom, you deliver on the second one. Okay?
Okay.
So the amplitude of there can be some debate about the amplitude of the first shock. Here in this patient, it was a very, very small patient, only 30 kilograms, and with very fast polymorphic arrhythmia and syncope. We decided, we have implanted this patient and we have tested during the implantation, and we have tested low amplitude shock in a ventricular fibrillation. We have tested, if I remember, 8 or 10 joules, and it was efficient twice in 2. So this is why we decided to program it. This patient is only 30 kilograms. Maybe it's not required to deliver maximal output shock in this kind of patients. He had quite a few episodes of ventricular fibrillation. Anytime the 14 joule was efficient with reduction of the arrhythmia. So the question here, and at the end, he received shock, and that's a matter of debate. I'm not sure it's a good idea, but he received shock while he was quite conscious. He did not lose conscious every time. I don't know if it's a good point or a bad point in this case. So 14 joule, because we didn't want to hurt the myocardium, and also I think that since it's efficient, maybe it's not required to program more. Of course, in this patient, the second, in a Boston device, you can program up to 8 shocks in the ventricular fibrillation zone. So the second to 8 was 41 joule in the programming. But for the first, we decided to shock quite early with quite low amplitude. And in this patient also, it was very polymorphic. You see the aspects. And there was quite a lot of undersensing. You see here undersensing. Undersensing, and that's one of the reasons why we have decided to program a short duration, because there were some episodes with quite a lot of undersensing, and the more you were weighted, the more there was undersensing. That's the reason why we have decided to program a short duration. But of course, we could debate on the interest of this or not. Okay, so the conclusion of this is, in most of the patients now, we only program maximal output shock in the VF zone, okay? But there can be some specific situation, for example, pediatric patients where the amplitude required to defibrillate is sometimes much less than in the adults, okay?
Yes.
Good. Next tracing, now it's an adult, and you see an episode with 1 shock, 2 shocks, 3 shocks, 4 shocks, 5 shocks. And if you look at the tracing, initiation of an arrhythmia here. Okay, yep. So it's always the same. 1, 2, 3. You need first 3 consecutive fast cycles here. 1, 2, 3 consecutive. And then 1, 2, 3, 4, 5, 6, 7, 8. 8 out of 10 for the VT zone, but on the next cycle, it's the 8 out of 10 is fulfilled also for the VF zone. So at this time starts the duration for the VF zone. After 5 seconds here, V detect. During these 5 seconds, always 6 out of 10. Then we'll start the charge of the capacitors. At the end of the charge, 135 milliseconds of banking. Next cycle, unclassified, 1, 2, fast cycle, we deliver on the second one. And what do you think about the effect?
Well, it's inefficient.
Yes, it seems not to be efficient. There is a doubt every time, but I think this is non-efficient. Okay, so now what is the counter now? How does it work?
Now it's the redetection counter.
Yeah.
And it's 6 out of 10.
No. At this time, after the shock, you need also once more to refulfill the 8 out of 10 first.
Okay.
So it's going to be 1, 2, 3, 4, 5, 6, 7. You know, this one is not good, and 8. So 8 out of 9 here. So it's 8 out of 10. There is no marker here. There's no marker V episode for the redetection. But all the time, it's quite demanding. You need 80% of fast cycle after the shock. So that can be a problem in some patients. If there is a little of undersensing in case of inefficient shock, it can be a problem. But from this, at this time, you need all the time to have 8 out of 10. Okay.
Okay.
And at this time, we'll start the post-shock duration. Okay. During the post-shock duration, and it's going to be fixed in the VF zone. You cannot reprogram it. It's going to be 1 second. Okay.
Okay.
In post-shock, so 8 out of 10 and then 1 second. And during this 1 second, you still need to have 6 out of 10. Okay.
Okay.
And then you start the charge of the capacitors. The first shock is non-committed. The second one is committed. It means that if you charge the capacitor, whatever happens here, you will deliver the shock at the end of the shock, at the end of the charge. You understand?
Yes.
You cannot divert this one.
Do you have the possibility to unprogram committed shock in Boston device, or?
Yes.
Okay.
It's committed means that there is no confirmation for the first shock.
Okay.
Non-committed, it is what you want. What you want is a confirmation for the first shock. But the second out of 8, they will be committed, whatever
you program. Okay.
Yes.
It's only for the first shock that you can program committed or non. Okay.
Okay. So you go to the end of the charge. And at this time, you know that you will deliver the shock. But there is still this 500 milliseconds divert window. It's always present, even from 2 to 8. But whatever here, after 500 milliseconds, you will try to synchronize on a cycle and deliver on it. Okay, it's not a question here of 2 out of 3. You understand?
Yes.
From this time, you will work for 500 milliseconds, and then you will deliver on the cycle, the next cycle after 500 milliseconds. You understand?
Yeah.
Okay. So the same here. It's, I think it's inefficient. That's a debate here, but I don't think it's. I think there is still, and it's obvious after there is ventricular fibrillation. Now the counters. So RVS. Okay. 1, 2, 3, 4, 5. 5 out of 6. 6, 7, 8. At this time, you have fulfilled the 8 out of 10. Okay. And then the duration, 1 second, and then still the same. Okay. Charge of the capacitors. End of the charge. You wait 500 milliseconds. You deliver 8 out of 10, and so on. Okay. For a maximum, you see, sometimes it's surprising. I've seen in many cases in Boston device. I don't know the reason here exactly, but it seems that there is a doubt about a reduction and a reinduction. In fact, you see.
Yeah.
Very fast reinduction of the ventricular fibrillation. I'm not sure I will say this shock. It's important after to know if it is efficient and then spontaneous reinduction of ventricular fibrillation, or if the shock is non-efficient. It's not exactly the same than what you will do for the patient. Okay. But I would say that I'm not sure at all that this shock is efficient at all. Okay.
Yep.
And you will go up to a maximum of 8 shocks. Another patients, if there are any questions, do not hesitate. The same, you see, a patient will receive many shocks. What do you think here?
So once more, we have more V's than A's.
Yep. So it's ventricular arrhythmia. It's organized, monomorphic. Yeah. You agree?
Yeah.
1, 2, 3, 4, 5, 6, 7, 8 V episode. Then start the duration.
Yep.
For the VT zone. But spontaneously, you see that at one time there is an acceleration here. You see here, 1, 2, then 3, 4. You will have now the 8 out of 10 that is verified for the VF. So then start at this time the initial duration for the VF zone. Okay.
Okay.
You see here, you have a diagnostic V duration. It means that on this cycle, the duration for the initial ventricular tachycardia for the VT zone is now finished. You understand? It has started here, the duration for the VT zone, okay? It's now finished, and you see the marker V duration. But at this time, the duration for the VF zone is still ongoing. You understand?
Yes.
So no therapy is delivered for the VT zone. So you are arrived to the end of the duration of the VT zone, but since the duration for the VF zone is still ongoing, no therapy, you will wait. And at one time, you will arrive to the marker V detect. It means that now it's the end of the duration for the VF zone. Okay?
Okay.
What you see here is an ATP. We will discuss about it, which is delivered in the VF zone. Okay? Obviously non-efficient. So it's a pre-charge before the charge ATP. Since the ATP is non-efficient, the arrhythmia is still ongoing. 1, 2 fast cycle, 2 out of 3, then we'll start the charge of the capacitor. Okay? In Boston, in the VF zone, you have the possibility to program an ATP, but it's going to be an ATP before the charge. Okay? You deliver the ATP. If it is not efficient, then you will start the charge of the capacitor. Okay? So you will charge. At the end of the charge, a shock is delivered. And it's the same that in the previous tracing. I don't think the shock is efficient, but what you see after, what do you see after?
We have a few V-sense and then PVC, and then it generates again into a very
not
fast.
Again. First, it was
it's not again, but now it's very fast.
Very fast
polymorphic arrhythmia.
So degradation between organized VT to ventricular fibrillation. Okay. I think it will be interesting, but I don't know exactly what I see is that you organize before, and then after the shock, you see the very fast and polymorphic arrhythmia. Okay?
Yeah.
So at this time, redetection, 1, 2, 3, 4, 5, 6, 7, 8, and then start the post-shock duration for the VF zone. Once more, you cannot reprogram it. It's going to be 1 second. If the shock is considered inefficient, then 8 out of 10, and then start a duration for 1 second. During this duration, you need to have 6 out of 10. At the end, you arrive here, end of the duration, the redetection, and then we'll start the charge of the capacitors, okay? Still the same, at the end of the charge, 135, unclassified, 1, 2, but after 500 milliseconds, you will deliver the shock. And once more, the efficacy of the shock, we can debate about it. This is what see the leads, but maybe that there is ventricular fibrillation somewhere far from the tip of the lead. You understand that? And I think that the shock, I will consider the shock as inefficient here. Okay?
Yep.
Much more than a real efficacy of the shock and then reinitiation of the arrhythmia. So the same 1, 2, 3, 4, 5, 6, 7, 8, and then a new shock is delivered and charge of the capacitors, and then once more reinitiation, the same. So the point of this tracing is to explain this. In some patients, you see here that the shock will completely disorganize. So you are in VT, and then I really believe that the induction of the arrhythmia is related to the shock. And that's the idea of the upper limit of vulnerability. It means that the patient where the shock can be arrhythmogenic, like here, organized VT to ventricular fibrillation, are also the patient with the high thresholds. Okay, and that's one of the reasons why some patient will die with an ICD, because the shock will turn an organized and monomorphic arrhythmia to a ventricular fibrillation. And in this case, there is a high risk that the shock will not be efficient after for the reduction of the arrhythmia, since there is a direct relation between the amplitude to create an arrhythmia and to stop an arrhythmia. Okay? And that's one of the main problems for the patient with the ICD. When there is a high threshold, you have a risk not to be able to defibrillate, but we know also that in this specific patient, there is a high risk of induction of life-threatening arrhythmias. Okay? Yes?
Yes,
You are still...
I'm still there, but I have to go. Sorry, I will catch up with the recording of the session.
Okay. Sinan, are you here? Les internes, est-ce que vous êtes là?
Yes.
Yes, good. So next tracing, you see here?
Yes.
41 joules, and you see VF ATP delivered prior to shock. So now you have the possibility to program an ATP also in the VF zone. Okay, there have been many studies conducted most of the time by Medtronic, pain-free trials demonstrating that even in the VF zone, there was an interest in programming an ATP. So let's have a look to the tracing. What do you think here?
So we have a beginning of tachycardia, a ventricular tachycardia.
Yes.
The VF zone.
Yes, detected in a VF zone. Okay. The counter for the VF and the VT is the same. For Boston, it was the same. So what are the different steps? 1, 2, 3 fast cycles. Okay. And then 1, 2, 3, 4, 5, 6, 7, 8 out of 10. This is something that you cannot reprogram, this 8 out of 10. So at this cycle, the 8 out of 10 is verified for the VT zone. On the next cycle is verified for the VF zone. For any reason, it's quite old programming here. The duration has been programmed to 1 second. Okay. So what happens then?
Then we have the duration. So we have the marker V detect for
the end of the duration for the initial VF zone. Okay.
Yeah, for the VF zone. So it's 6 out of 10.
During this, you need to have 6 out of 10. That's the case. What happens here?
We have an ATP.
Yes, an ATP. This is what is called the quick convert. The quick convert is the ATP during the in the VF zone. Initially, on the old devices, you cannot reprogram it. It was systematically a burst with 88% on the pacing cycles and 8 beats. Now you could not program it for tachycardia faster than 250 beats per minute. Okay. If you remember the guidelines, I will show you the guidelines. Just if you remember the guidelines, you see the quick convert on up to 300 bits per minute in the VF zone, and the VF zone starts at 250 bits if you respect the guidelines. So the quick convert is programmed for tachycardia from 250 up to 300 bits per minute. I don't know if there is a lot of literature demonstrating the interest of ATP for such fast arrhythmia. The pain-free trials, the limit for the arrhythmia was 230 beats per minute. Here, you will program ATP, okay, if you respect the guidelines, from 250 up to 300 milliseconds. Here, you see, now you can reprogram it, some of the parameters, but ATP is delivered, and what happens?
And we have the reduction of the tachycardia.
Yes, it has been efficient. So at this time, you do not start in some devices, for example, in Biotronic, you will start the charge at the time you deliver the ATP. It's not the case here in Boston. You first deliver the ATP, and then you analyze the cycles. The next one is unclassified, always after the ATP, okay? But then you will analyze the next 3. And if 2 out of 3 are fast, then you will start the charge. If 2 out of 3 are slow, then you will divert the charge. No charge will be, you will not start to charge the capacitors, okay? So here it's efficient, so 1, 2, you will have at least 2 out of 3 slow cycles, so no charge will be started, and you will see the marker diverts, okay? It's clear? Yes.
Yes.
If you divert the charge, that's something also important. You will see the marker V episode end, like here. If during 10 seconds, you will not see anymore 8 out of 10 fast cycles, okay?
Okay.
At this time, you will say, I'll divert the charge. I will not charge the capacitors. And then I will try to find if at one time there is once more 8 out of 10. If not, after 10 seconds, you will see the marker V episode ends, okay? And then you will restart to 0, okay? And then if you see what happens after in the same patients. So it's, you are there, and then what happens?
Then we have the beginning of a tachycardia, ventricular tachycardia again.
Yes, the same, more or less the same.
Yeah, the same tachycardia.
What happens? So once more, since it's a new episode now, you understand? It's a new one. Since you have seen the marker of the episode M before, it's a new episode. Then you can deliver another ATP during the quick convert in VF zone. Okay. What happens here?
The ATP is not effective.
Okay, so the next cycle after the ATP is unclassified, and then 1, 2, you see 2 fast cycles. Therefore, you will start the charge of the capacitor. Most of the time, there is a delay between the second and the marker charge, 300 milliseconds delay, but that's a detail. Okay, you will start the charge of the capacitors. Okay, okay. So somewhere you have lost, let's say, 3 seconds before charging to see the effects of the ATP. So delivery of the ATP and then verification after the ATP, you will lose something like 3 seconds. If you had started at this time the charge of the capacitor, you would have started the charge maybe 3 seconds before in this example. Okay? Okay, you charge the capacitors, you go up to the end of the charge. At the end of the charge, blanking 135, next cycle is unclassified, 1, 2 fast cycle out of 3. Then you delivered after waiting at a minimum of 500 milliseconds here, okay? And then the shock is efficient. But for the marker V episode ends, as I said, it's 10 seconds if you divert the charge. You will see the marker V episode end after 10 seconds. But if the shock is delivered, now it's 30 seconds. You will consider that the episode has ended if for 30 seconds there is no 8 out of 10 fast cycles. It's clear?
Yep.
But you see here, still okay. And then once more, a new arrhythmia. Okay? Before the 30 seconds. Okay? So VF, V detect. And then eight out of 10 is here, then 1 second of post-shock redetection. It's going to be 1 second here. And then there is no ATP delivered because the quick convert can be just delivered once for the same episode. You understand? Yeah. You can have ATP delivered in the VF zone only for the first shock. If the first shock is somewhere considered as non-efficient, that's the case here, in fact. Okay? You understand? It's obviously efficient, but there is no end of episode, so it's shock number 2 now.
Yep.
And then you cannot deliver the ATP on this one. Okay? So this, you need to understand how it works. The end of the episode is quite long post-shock in Boston devices. It's going to be 30 seconds, okay? And that can be a problem sometimes. For example, here, what you will have liked here, it's organized. You will have liked that an ATP is delivered in this specific example, but that cannot be possible because this is considered as the second shock of the episode.
Yep.
You understand?
Yep.
Okay. ATP delivered prior to shock. Okay, what do you think here?
So I think we have the beginning of a tachycardia, ventricular.
The onset of an arrhythmia. Okay, if you consider the count, you need first 3 consecutive cycles. So this one, but then it's obvious. So it's not 1, 2, 3. Then 1, 2, 3, 4, 5, 6, 7, 8 V episode for the VF zone is start here. Once more, it's a short duration, and then you arrive to the end of the duration, initial duration. Now we program longer duration. It's going to be 5 seconds. Here it's probably something like 2 seconds. And at this time, an ATP is delivered. Okay, what do you think?
I think the ATP is not effective.
Not only it's not effective, but you see before and after, there is clearly an acceleration from a quite, it's not perfectly organized here, but it seems to be quite organized to a real life-threatening arrhythmia, ventricular fibrillation. What I wanted to show here is that, okay, it's not completely true to say, okay, in the VF zone, I will try to pace. If it does not function, so I will deliver an ATP, I will deliver the shock, but that's not a problem. Sometimes it can be a problem because in some patients, it's not the same to deliver a shock on this arrhythmia and on this one. Okay, here you really need to be efficient because if not, the patient will die. Here, maybe that he will not die. Remember always that when you pace and you try to deliver ATP in the VF zone, but also in the VT zone, of course, there is a good chance of reduction, which is a good point. You will avoid the shock for the patient, you will avoid the charge of the capacitors, and you will decrease the drain of the batteries, but there is also a risk of acceleration. Okay?
Okay.
And once more, for very fast arrhythmia, I don't think that there is a lot of literature demonstrating the interest of ATP. I don't say you should not program ATP, that's not what I want to say, but at least I can say that there is not a lot of data, and that's what we are working right now with Mark, just to measure the number of time where the ATP is efficient for tachycardia faster than 230 beats per minute. Okay? What do you think here? Very simple tracing.
So beginning of ventricular tachycardia, 3-5 cycles, and then we are in
1, 2, 3, then 8 out of 10, and then you will go up to the end of the duration. That's supposed to be 12 seconds now, at minimum of initial duration for the VT zone, and then an ATP is delivered. It's a burst or a ramp?
It's a burst.
Yes, it's a fixed cycles. In Boston devices, you will program both the pacing cycles and the initial coupling of the first cycle. It can be different. You understand that?
Yeah.
You can ask for long. You will program this interval, but also this interval in percentage of the previous ventricular tachycardia. The rate of the tachycardia will be measured on the last 4 cycles before the V detects. We'll say this is the frequency of the rate of the arrhythmia, and then you will program the coupling interval, which is the first one, and then the paced interval, the next one. Okay. If you remember, it's quite precise in terms of seeing the VT. It's not in the guidelines. They highly recommend to program burst more than ramps because the ratio between reduction and acceleration is much better for the burst than for the ramp. But at a minimum of 8 pulses, this is what is recommended. And a coupling, it's precise once more, 84% of the rate of the arrhythmia. Okay, and then you can program a decrement from one burst to the other one. It's clear?
Yeah.
Okay, so the example I've shown you is simple. This one, an ATP, it is efficient. Okay. Now let's have a look at these patients. Burst, ATP, ramp. Okay. So once more, a real arrhythmia. Okay. On this one, 8 out of 10, then start the duration. It's always the same. It's quite simple to understand. And then you arrive to the end of the initial duration. You see, initial duration. So from the V episodes to this, you have program, I think it's in the patient, it was a duration of 15 seconds. Okay. So you need to have an arrhythmia that will last for at least something like 16 to 70 seconds before delivery of the ATP. Okay, it's a burst now, and the coupling and the pace interval is the same. Okay, and at the end, the ATP is efficient. Okay, what happens then?
We have this same tachycardia.
The same exact tachycardia. Okay, but you see, from here to there is less than 10 seconds.
Yeah.
Okay, so it's still the same episode that is ongoing. Yeah. Okay, so you need to understand how it works. It has been efficient, but then you will require the 8 out of 10. 1, 2, 3, 4, 5, 6, 7, 8. Okay, and then start the confirmation duration here in the VT zone. Okay, and nominally it's going to be 1 second, and that's the case here. But you can modify it. This is something that you can reprogram. What I wanted to show you is that on the previous one, you have waited before delivering the ATP for a duration, initial duration of 15 seconds. Okay,
yeah.
But now you treat much quicker now. Okay, since it's considered, to be the same episodes, the duration here is 1 second, and then you will deliver the ATP. Okay, still efficient, and then restart, and the same. You see the time from the first beat of arrhythmia and the moment you deliver the ATP is quite short. So really in these patients, we know that we program much longer initial duration than we were doing before. Now it's nominally, at least in our center, a minimum of 12 seconds. Of course, we need to adapt to the characteristic of the patient, but we try to wait quite long before delivering the ATP. So I would recommend, if you do this, to also prolong the redetection duration in the VT zone also, okay? Because if not, if there is restart, new onset of the arrhythmia just after delivery of the ATP, and this is not infrequent, then you will treat very fast, okay? You understand? Yeah. You see, from here to there, it's very fast because it's considered to be the same episode all the time, okay? Okay, I will no point to this one. What do you think here? You see the burst, the ramp. Now let's consider the time of the arrhythmia here. You see 30 seconds is the time before delivering the ATP, because we have programmed quite long duration in this patient, okay? Then 4 bursts are delivered. Then the ramp, if it is non-efficient, will start. It's 56 seconds. And then in the VT zone, usually we program a shock, and we will discuss about the amplitude of the shock. Here it's 11 joule in the ventricular tachycardia zone. And it will be delivered after 1 minute and 30 seconds after the onset of the arrhythmia. So you see it's the same patients here, ATP. You see here it's 10 seconds.
Yeah.
The episode end. So now you restart to 0, but there is a new onset of the arrhythmia. So the initial duration is quite long. We wait, and then ATP is delivered. Okay.
Yeah.
Then the counter for the redetection: 1, 2, 3, 4, 5, 6, 7, 8. and then the 1 second here. So you retreat quite fast, okay? Still non-efficient. It's a burst, okay? Non-efficient, still a burst. And then the next one is a ramp, okay? So there is a debate here on the interest of the ramps. The ramps, I think the efficacy of the ramp is a little, Mark Strick has worked on this one and has published a paper, and we demonstrated that the ramp were more efficient, but of course with a higher risk of acceleration. So it's a debate, should we or not program the ramps or only burst? There are, I don't know if it's a question of countries, but when I have traveled a lot, it depends on the country, on the fact that physician will or not program the ramps. Okay, so the ramp here is non-efficient. Then the one, this ramp is efficient, but new induction of an arrhythmia, new onset of an arrhythmia here before the 10 seconds. So the last ramp, it's considered to be the same episode. You understand now? We not restart the therapy that's a problem here in Boston. When you have patient with repetition of arrhythmia, reduction, new onset before this delay of 10 seconds, but at the end, the patient may receive a shock. You see here, we should restart to 0. You understand?
Yeah.
Okay, with an ATP, but that's not the case. That's the last ramp, this one, and then the shock is delivered because you have delivered 4 bursts, then 4 ramps, and then the shock, which is the next therapy in the VT zone, okay?
Yeah.
In the VT zone, you can program up to 6 shocks. In the VT1 zone, you can program up to 5 shocks. It's 8 shocks in the VF zone. It's clear?
Yeah, okay.
Okay, so here the patient received 11 joules, but that's something that should be avoided. But that's a problem. It's very difficult to avoid it because you cannot modify this criterion of end of the episode. You understand?
Yeah.
Okay, so 11 joule is efficient. So if we come back to the guidelines, they recommend only maximum output even in the VT zone. Okay? Clear? Yeah. I think this one we have seen it. Also this one. So what do you think here? Ah, shit. I don't think, sorry. I'm not sure I have the good tracing I want to show you. Yes, this one. So once more, you see burst, ramp, 11 joule, 41 joule. That was something we were used to program in Bordeaux. For quite a long time, we have programmed this kind of shocks as the first amplitude with something like 10 joules in the VT zone. Okay? But, so it's a VT, the ATP are non-efficient. I will go up to the end. Non-efficient, 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 non-efficient. And then the 11 shock is delivered. Okay, so VT, all the bursts are non-efficient. So what 11 joule is delivered? What happens?
Then we have still have a tachycardia in the VF zone.
There is a clear acceleration. Okay, this is not life-threatening. The patient is still conscious. It is really a VT, but you're close to 400 milliseconds, so 150 beats per minute. Okay, so the patient will feel the tachycardia, will not be very well, but he is conscious. And at this time, you receive the shock, and then you induce a very, very fast and life-threatening arrhythmia. Is clear?
Yep.
So once more, remember, when you implant an ICD, an ICD will save some lives, for sure. Ventricular fibrillation, shock delivered, the patient is alive. No ICD, death of the patients. But remember that when you implant an ICD, you will also, may in some patients, induce life-threatening arrhythmia. Okay, here, this is the ICD that create the life-threatening situations. Okay, and remember that it's the patient with the higher threshold who have the higher risk of induction of fast arrhythmia. Okay, by the ICD. By chance here, the 40 joule is efficient. So probably the threshold in terms of defibrillation is in between 11 joules and 41 joules. Okay, but at the end, the patient is alive. The problem is that if, for example, there is induction of ventricular fibrillation because of this 11 joules and the threshold is very high, then the patient, the shock will not be efficient then. And then you will not see anymore the patient because the patient is dead, in fact. You understand that?
Yeah.
Okay. So today, we now program this kind of programming here, like here, burst, ramp, and maximal shock inside the VT zone. Okay. At least I don't program these low amplitude shocks. We have done a study with 40 episodes of shock delivered in the VT zone, 40, and something that 10 joule was efficient in 35 cases, 35 out of 40. But there was an acceleration in 5 patients with life-threatening arrhythmia and quite scary arrhythmia. Okay.
Yeah.
So I don't know what to do from this study. Should we keep on programming 11 or 10 joule in the VT zone or only 41 joule? What we do today in our center is most of the time to program only maximal output shocks, even in the VT zone. Okay?
Okay.
And the last tracing, this one. This is a patient with ventricular tachycardia and many episodes of ventricular tachycardia that were interrupted with ATP. But there is also this case in this patient. See, what do you think here?
So beginning of ventricular tachycardia.
Yep. If you look at the marker, 1, 2, 3, 4, 5, 7, 8, the episodes, okay? Then start the duration for the VT zone. It's organized, you agree?
Yeah.
It's something like 200 beats per minute. Then ATP is delivered, and what happens?
We have an acceleration of the arrhythmia.
Once more, fast but organized, maybe not life-threatening arrhythmia to a life-threatening arrhythmia, the ventricular fibrillation now. Now you need to have the shock to be efficient. If not, the patient is dead. Okay? So maybe this patient will never have presented any episode of VF spontaneously. But this is the ICD which creates. Okay? So the point here is to discuss, and that's as much as possible, I want to avoid the treatment of organized ventricular tachycardia slower than maybe like 200 beats per minute by the ICD. Okay? The ICD is there to deliver therapy for very fast and life-threatening arrhythmia. That's the new idea now in the programming of the ICD. You want to avoid to treat organized ventricular tachycardia like we were doing before. 10 years ago, in our center, we were treating all the ventricular tachycardia from 150 beats per minute up to 200 beats per minute. We wanted to treat them. But now we want to avoid it because in this patient, he had, I don't know how many episodes of VT. In most of the cases, the burst was efficient, but in at least 2 or 3 cases, the burst induced ventricular fibrillation and life-threatening ventricular fibrillation, and the patient received a shock. So even in this patient, if the ratio of success is something like 90%, in the 10 other percent, there is an acceleration and a life-threatening situation for the patient. So I don't think in this patient, I want to avoid it as much as possible. So the problem is that we know that the medical therapy are not very efficient in these patients. Maybe the ablation should be proposed, but really we want to avoid as much as possible that the ICD is used to treat, organize, and not too fast ventricular tachycardia, okay, because of this risk of acceleration. If in this patient there is a high threshold for defibrillation, then the patient will be dead because of the ICD. You understand? Any questions? No. If not, next week we're going to discuss about discrimination in Boston ICDs. Okay? Bye. See you.